We are open to questions, so this is an opportunity to ask specific questions, pick on someone individually, or just to ask a general question. We do this at the end of every session. Isn't this cute? Have we got a photo of this? Excellent, excellent. All right, we've got one mic up here, which means I'm going to have to run around a little bit. So hands up for questions.
Hello, I've had ITP for 52 years. I was just turning 18 when I was diagnosed, and there was no such thing as ITP Australia. There was no Google, there was nothing. And I was in Tweed Heads, so I got nothing. My question is now, with platelets, with ITP, our platelets are large and sticky, correct? So we get a machine count. But if an optical count is done, it's different. Can you please explain that, somebody?
Yeah, so back in the day when the Harrington-Hollingsworth experiment was done, as I pointed out, a normal platelet count was regarded as about 800. In those days, they used to do what's called a manual platelet count, which is looking down the microscope and making an assessment based on physically counting within little squares. Sometimes that still happens, and it can happen if you don't trust the machine count. So you're correct, platelets and ITP are larger than in the general population, and they're young platelets, so they generally do function very well. Because they're larger, the way that machines count platelets is by their size. So if something is bigger than a certain size, and that size is about 30 femtoliters, it's counted as a red cell. If it's below, it's counted as a platelet. So if you have what's called an impedance hematology analyzer, it'll just count based on less than 30 platelet, greater than 30 red cell. If it's an optical counter, it will analyze the properties, if you like, of the cell rather than just the size of the cell, so it can sort out between platelets and red cells, not based on size, but based on other characteristics. So in fact, an optical count is more reliable. I think these days most analyzers have both capability of performing both an optical and an impedance platelet count. Sometimes I do get some patients who consistently get an underreporting of their platelet count. The other situation, sorry, it's not directly asking a question, but the other situation you sometimes find is when patients come to see me in clinic, they have the blood test done. That morning, the blood goes to the lab within half an hour, it's processed within half an hour. So we get a needle to result within 1 hour if people see me at the hospital. Whereas if people get their blood taken in the community, they'll have their blood taken, it sits around for some hours sometimes, waiting for the courier. Then the sample bounces around in the back of the courier van going to the lab. Then it goes on to a sort of rack waiting to go through the analyzer. So it can be, in fact, you often don't get a result until the following day. And my observation certainly has been in those patients who get their blood taken and it processed rapidly, the platelet count is generally higher than when patients get it done in the community. So what I'm saying is there are a number of reasons why platelet counts might be falsely low, but certainly an optical platelet count is a more accurate way of measuring platelets than an impedance platelet count, but most modern analyzers are capable of doing both, and preferentially we do an optical platelet count in people who we know have large platelets. So this is a very long answer to a very short question, but the machine will generally flag large platelets. If the mean platelet volume measured by the impedance counter is high, it will generally default to an optical count. So whereas we used to have to specifically ask for an optical platelet count, now you generally get one pretty much automatically.
Just a side question, do you still use platelet survival studies?
No. Short answer is it's a long time since anyone's really reported on that. It would be interesting to do in certain situations, but it often involves radiation.
Outside of a cure, what's your hope for people living with ITP in the next 10 years?
Awareness.
Does it have to be one word?
Do you think of the next year's marketing slogan?
In the next 10 years, I hope that we'll be able to diagnose ITP into different types of diseases that we can actually treat without using a shotgun.
I hope that children and their families can do the activities they want to do and have the care arrangements that works for their families.
I'd like to, building on what Phil said, really at diagnosis, work out, the mechanism of each individual's ITP, because clearly the fact that people respond to different treatments means the underlying kind of pathology is different. And I'd like to be able to do some kind of analysis right at the beginning so we can use targeted therapy that will prevent each individual's newly diagnosed ITP from being a long-term problem. So in other words, a cure right from the start, and then there'll be no need for any of these meetings or any, So it's almost like, we'll put ourselves out of business, but hey, that's the goal.
Our sponsors are sweating at that comment, right? Don't just erase that, rewind. I'm really hoping to see the long-term data for some of the promising new agents. There's very exciting stuff coming up, and there's stuff that I think me and Phil signed CDAs for that we can't talk about. That's very promising. Just new immune therapies that seem to be more targeted and potentially effective in eradicating these sort of memory cells that are perpetuating this disease. So yeah, I'm an optimist, baby. Cure, yeah, why not? 10 years, maybe. I don't know. Yeah.
Hello, thanks so much for today. I'm a noob, I'm 6 months in. I'm just wondering about if there are any differences in the way treatments are offered, whether you're in the public or private system, or is that more to do with your haematologist and their knowledge and background?
I guess, so I'm predominantly public, but I do have a private practice. In fact, that's where Caitlin first met me. No difference at all in terms of our approach. We're kind of very blessed in our amazing PBS system, really, that really we could access, equally the treatments in the public or private setting. Has zero impact in my mind in terms of how we treat a patient. Yeah.
Thank you. Quick follow-up question then. Just in terms of clinical trials, and I've learned recently about compassionate access.
Yep.
Can you tell us a bit about compassionate access and how that would work with new treatments?
Complex question with complex answer. So only for some selected medications, and it's not always guaranteed when you apply for them that the company would approve. Yeah. So.
Thank you.
I guess there's sort of two scenarios for compassionate access. When a clinical trial is completed, usually the sponsor will undertake to provide the drug to responders until the drug becomes available on the PBS. So commonly a clinical trial will wind up and then shift to a compassionate access program to bridge the gap. So that's one thing, and that's pretty much straightforward. If you're on the trial, you'll carry on getting the drug. So that's the easy way. The other way is for people who are failing to respond to treatments, and you may approach a drug company. So typically it'll be for a drug like, say, daratumumab, which is licensed in Australia and it's reimbursed in Australia for myeloma, but not for ITP. And then it's really a matter of just approaching the company, explaining the situation, and really it's up to the company whether they will supply the drug or not. Obviously we live in a sort of odd situation where, as specialists, we have to have a relationship with pharma companies to do clinical trials and to get access to drugs compassionately. But our employers have this thing called conflict of interest, which is an important concept. But conflict of interest, I call it more commonality of interest, because we have a common interest which is the disease we're treating and the drugs we're using. And, you have to develop a relationship with sponsors to get drugs on an access program. At least your chances are better if you do. So certainly my experience in the past has been I've been met with an amazing positive response rate. I guess if you don't ask, you're never going to get. And if you've had a pre-existing relationship with sponsors through treating other conditions, then I guess they know you and think you're a reasonably sound person. And I've got some very difficult to treat patients. I was going to say difficult patients. They're not at all difficult, but their disease is difficult. And I've been able to get a huge range of drugs on access programs. Did you want to add to that?
No, I think that's a perfect answer. There are some... I was only going to say there are some clinicians or haematologists that you might encounter who won't have the time or the confidence to approach some drug companies. And then you have others who've done it so many times before, they're not shy. And so sometimes it does involve just asking your haematologist again and again if that's the direction you want to go.
My daughter is new to the journey of ITP, and what was interesting was the young girl's story of Dapsone and then your story on Dapsone, and I have a script for Dapsone on my fridge. And as a dad, I just did you get spoken to about the side effects that these two brave people have spoken about just now? She said no. So, Danny, your presentation on SDM, well, I was going, okay, I'm getting this now, right? Because I'm not seeing it. But when you're looking at medication, is there any way or is there anything predisposing that says that medication is going to have some side effect to my patient? And how do you, I'm assuming you explain that, but that hasn't been explained in my circumstances that I'm aware of. So is that something that is normal? Is it not normal? Because
great question and comment. And I think the aim of that SDM talk is really to empower you as carers of and patients. You could absolutely ask Dr. Hold on. You give me a script for this. What are the side effects? Because a lot of doctors are not going to invest in the time to go through all the side effects, right? And it's not because they don't care what not, because, we know, at a specialist clinic there might be chockers and they don't have the time to sit down and go through everything, but there's nothing stopping, any of you in this room just say, time out, I get that you're busy, but, this is my daughter here, what can I expect as a potential side effect, from Dapsone? To your question about can you predict some of the side effects, for Dapsone, in a way, yes. So we know it breaks down, it puts extra stress on the red cells. That's why they break. So in patients of, Mediterranean or Asian ancestry, you could inherit a very common red cell problem that you might not know you have called G6PD deficiency, where the red cells could break down spontaneously on their own. Those patients almost certainly will get severe hemolysis and can be very severe hemolysis if they're exposed to a drug like Dapsone. So that should have been screened initially, which sounds like I don't think Caitlin had screening, and is that from your laughing?
you said G6PD.
Yeah.
My nephew has it.
Oh shit. Yeah. So high. Oh, red flag. So do not start until you get screening, will be my advice.
Thanks for that.
Pleasure. SDM, baby.
My question is also medication related, but just on the opposite end of the expense and side effect spectrum, really. And with respect to this card, where it says on the back, do not administer anti-inflammatories, including aspirin and ibuprofen. So I'm in a different age group, and I have chronic ITP. I've had it for 2 years, and I've had, in that time, I've had a number of episodes with healthcare professionals where aspirin and ibuprofen separately have been strongly indicated. And when I've asked about it, the people have said, absolutely, yes, you can take it. So my question is, interested to see what the professionals' advice would be. Does it depend? Is it absolutely a no-no to take those medications if you have ITP, or is there some advice you could give?
Relative risk, yeah, I guess it's all about relative risk. Aspirin specifically really prevents complications of vascular disease like cardiac disease, strokes and so on. And there's another drug, clopidogrel, which does a very similar job. They would increase the risk of bleeding if you had a low platelet count, but it would very much depend on the risk of vascular disease. So if you had known coronary artery disease. The other thing would be, the stability of your platelet count. So the problem is a lot of people with ITP will have a very highly variable platelet count, much more variable than people who don't have ITP. And, you can dip down, so certainly if people have high risk vascular disease, then you'd certainly want the platelet count to be above 30. If it was a lower risk, you might say it's settled for 50. But certainly, if it was really high risk vascular disease, there may still be a benefit of using aspirin. With non-steroidal anti-inflammatory drugs, really, it's continuous exposure to those that's more of a problem in terms of the antiplatelet effect and the effect on your stomach and the increased risk of bleeding. So if you have ITP, you don't necessarily have to turn to opiates for painkillers. You could take a Brufen or a drug like that as a sort of one-off without really high risk of a problem. The problem would be in a course, if you like, of continuously taking the drug when it would have then a ongoing antiplatelet effect plus the gastric effect. Do you want to add to that?
Just to say that there are very few hard rules in treating ITP. The only rule would be every drug has a side effect. And so never accept a doctor giving you a script without some recognition of there being some risk. But in terms of exactly what Rob was saying, that there'll be, and we know ITP is an increasing problem as we get older as well, and vascular disease becomes more prominent. We have a lot of patients who have to straddle both risks of having strokes and heart attacks, but also having bleeding from their ITP, and that's a reality we just have to live with as our patients get older.
And it also happens in the paediatric sector as well. We certainly have patients in paediatrics that have conditions such as congenital heart disease and also develop ITP, and consequently do have to have periods on both medications as well.
One question, when you look at a medication, a lot of them will say bleeding, bruising, even though you're taking it for ITP. And why is that?
Product information.
Well, it does depend a bit on the medication, but sometimes there's just a balance. A little bit like what I was telling you before with the diet, and some medications might increase the risk of bleeding, but they might help increase your platelet count.
Yeah, but a lot of drugs have thrombocytopenia side effect, yet you're still taking it and you think, should I be? Or is this just for legal reasons that they've put it in?
I think it's very nuanced, and it depends on the drug and the situation, and maybe we can talk about it in an appointment. Yeah.
A lot of it's to do with product information. So basically, when you're on a new drug is being developed on a clinical trial, very rigorous data is collected about adverse events, which we tend to call side effect adverse events. And if you're on a clinical trial, that data collection is very rigorous. So you'll often find drugs that are being used to treat ITP, one of the most common adverse events is bleeding, because people have got a reason to bleed because their platelets are low. So if you look at an ITP trial, one of the top reported adverse events is bleeding. And it's really not so much an effect of the drug you're using, it's the underlying condition. But the problem is once something's reported as an adverse event, it's on the list of adverse events. And if you read the product information from any drug you were prescribed, you'd run a mile and never take anything, because just about every side effect you can ever think of for any drug is listed. But what you've got to get is a kind of nuanced discussion with the doctor prescribing the drug to say, like with Dapsone, Stevens-Johnson, the very severe rash is a very rare side effect, but oxidative hemolysis, which is the red cell breakdown, is a very common side effect, and there's another one called methemoglobinemia. So you really need to know what the leading dangers are in your individual situation, I think, and it is a bit of, it's a bit of a risky process to read the actual list of potential side effects, because you would never start on anything if you consulted the product information.
Just a question on future research. With the latest breakthroughs in artificial intelligence analysing complex compound molecules, especially proteins, they've been coming up with generating new unknown molecules. Is any research in that area explicit to ITP that you're aware of?
Not so much in exploring different proteins, but we certainly are seeing more AI being used to try to help with diagnostic algorithms and with genetics, trying to sift through all the mutations that we find to start to get a better sense of what might lead someone towards a more difficult ITP or not. There's also a bit of AI being used in exploring the gut microbiome and the different bacteria and the genetics of those bacteria that again might predict response to different treatments. But that's sort of about as advanced as it is in what I've read so far.
The RSTH abstracts we reviewed, did you? So we've just had this period of, we review the abstracts, which is the sort of research people put in for the ISTH, the International Society on Thrombosis Hemostasis meeting in Washington, which is happening in late June. And several months beforehand, researchers put in their work, and then it goes to a sort of panel of reviewers. And I reckon probably 3/4 of the abstracts had some component of AI in the study, but in lots of different ways. There wasn't a common theme, but AI, it's kind of almost like the sexy thing, and people almost think if they haven't got AI, they're not going to be, not going to be successful. But yeah, it's a really big emerging thing, and people are trying to use it in any way they can, sometimes in ways that actually didn't make much sense, to be honest, but all useful. Very, very much coming in.
It's also from a different aspect. We know communication is so important. It's in some centres being used to dictate or to write letters back to GPs so your other specialists know what's going on. I certainly know some centres around the country are doing that, which can be time-saving or provide that communication that's not currently happening, which can be helpful.
First of all, I just want to say thank you to you guys. Thank you so much for your time. Your time, your energy, your empathy, putting up with my emails, the to-do lists, and just for everything. Like I said before, these guys are just amazingly beautiful, genuine humans that you want in your corner, ITP or no. So thank you so much to each and every one of you for everything that you do for the organisation, but for these guys as well. Thank you so much. We've touched on it earlier today as well, when it came to the shared decision-making talk as well. If you are in need of wanting to, get a second opinion, explore other specialists and have a chat, we do have a section on the website. Again, I'm talking about the website. Jump on there and have a look. All of these faces are in there, so feel free to jump in there and have a look. But as I said before, all of the vast majority of the haematologists that we deal with, that we work with, that we recommend are just like these guys as well. So always jump back to the website or get in touch. And lastly, and definitely not least, is thank you to each and every one of you who have travelled from near and far to come today. I think we said that it's more than half, people from more than half of the country, if we include New Zealand as a state. I know, it's so raw. It's not, it's okay. No, but thank you so much for each and every one of you taking the time to come today, for spending an entire day here with us. We can't do this without you. And I think I mentioned it yesterday, nothing about us without us, which is extremely important. And these guys are definitely advocates for that. Please take that home with your journeys, and not just in the space of ITP. I think everything that you do when it comes to your healthcare, physical, emotional, and mental healthcare. Nothing is as important as what you are right there and then. Yes, it may not be cancer, but what you're experiencing, what you're feeling is just as valid, and know that we've got your back, and we are in your corner, and I think most of these guys know I'm up for a fight. So, but thank you to each and every one of you for coming today, spending the time, and making the effort to come to Sydney, travel and be part of today. So thank you so much.